Welcome to Bipolar Talks, the channel where we mindfully explore the lived realities of bipolar disorder, without judgment, without stigma, and always with empathy. If you're joining us for the first time or have been with us on this journey, we invite you to like, comment, subscribe, and share this episode. Your support helps us reach more people who might be searching for answers, comfort, or simply someone who gets it. Today's episode is called Understanding Bipolar I and II, a deep dive. We're going beyond surface-level definitions and diving into the emotional, medical, and human truths behind these two types of bipolar disorder. From mania and hypomania to depression, diagnosis, treatment, stigma, and recovery, this is the full picture. So settle in, listen mindfully, and let's begin. Bipolar disorder is a mental health condition marked by extreme shifts in mood, energy, and activity levels. It's not just about ups and downs. These mood states are intense, often disruptive, and last for days, weeks, or even longer. There are several types of bipolar disorder, but today we're focusing on Bipolar I and Bipolar II. Bipolar I involves at least one manic episode that may be preceded or followed by hypomanic or depressive episodes. Mania here is severe and can cause significant impairment, even requiring hospitalization. Bipolar II involves a pattern of depressive episodes and hypomanic episodes, which are less severe than full mania. The catch? There is no full manic episode in Bipolar II. Yet, it can be equally debilitating, especially because the depression tends to linger longer. Let's break these down further. Mania is not just being energetic or excited. In Bipolar I, mania can be dangerously elevated mood. Common signs of mania include inflated self-esteem or grandiosity, decreased need for sleep, feeling rested after just a few hours, racing thoughts or flight of ideas, talking very fast, often jumping topics, distractibility, risky behavior, reckless spending, unprotected sex, impulsive decisions. Some people feel invincible, while others become irritable or paranoid. Mania can look like joy or rage, genius or chaos. And when it spirals, it can lead to psychosis, a break from reality. For families, it can be scary. For the person experiencing it, it can feel euphoric or terrifying. But make no mistake, mania can disrupt lives, careers, relationships, and safety. Next, let's talk about its quieter twin, hypomania. Hypomania is a subtler version of mania. It has the same symptoms, but they're less severe and don't cause major functional impairment or require hospitalization. That sounds like a good thing, right? Not always. People in hypomania often feel more productive than usual, extra creative, intensely focused or social, like they're finally themselves. But here's the danger. Hypomania can be seductive. It's easy to miss or mislabel it as a personality trait, especially for those who've spent years in depression. That's what makes Bipolar II tricky to diagnose. What follows hypomania? Usually crushing depression. Depression is often the longest and most painful phase of both Bipolar I and II. It's not just feeling sad. It's a deep, immobilizing darkness. Symptoms include persistent low mood, loss of interest or pleasure in things once enjoyed, changes in appetite or weight, sleep disturbances, too much or too little, fatigue or loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating, thoughts of death or suicide. In Bipolar II, depression can last much longer than hypomania. People may go months without realizing they're cycling. Unlike unipolar depression, bipolar depression often includes atypical symptoms like mood reactivity and hypersomnia. It also responds differently to treatment, especially antidepressants. This is why an accurate diagnosis is critical. It often takes years to receive a correct bipolar diagnosis. Many people are first diagnosed with major depressive disorder, ADHD, borderline personality disorder, anxiety disorders. Why? Because depression shows up first. Hypomania is easily missed. Mania may be mistaken for stress, creativity, or substance use. Misdiagnosis can lead to improper treatment. Antidepressants alone can trigger manic episodes in someone with undiagnosed bipolar. The turning point often comes when A manic or hypomanic episode becomes unmistakable. Someone keeps cycling between depression and brief elevated states. A clinician takes a thorough history, including family patterns. Still, it can feel like being lost in a maze. But the right diagnosis opens the door to real healing. Getting the right diagnosis is like finally putting a name to the chaos. The DSM-5 is the handbook used by mental health professionals to diagnose mental conditions. According to the DSM-5, a manic episode for bipolar I requires at least 7 days of elevated mood or activity, or any duration if hospitalization is required. It must include 3 or more symptoms, for if the mood is only irritable. A hypomanic episode for bipolar II requires at least 4 consecutive days, but does not cause marked impairment. A major depressive episode must last at least 2 weeks, with 5 or more symptoms, including either low mood or loss of interest. Real-life diagnosis is messier than checklists. This is where mood charts, journals, and daily self-tracking can be incredibly helpful. These tools give doctors a more complete picture over time. People may also go through psychological testing, interviews, and lab work to rule out other causes like thyroid issues or medication side effects. Diagnosis requires trust and honesty between patient and provider. There is no cure for bipolar disorder, but it is treatable. The goal is to stabilize mood, reduce the severity and frequency of episodes, and help individuals lead meaningful lives. 1. Medication. Mood stabilizers like lithium or lamotrigine. Antipsychotics, quetiapine, olanzapine. Antidepressants, cautiously used. 2. Psychotherapy. CBT helps change negative thought patterns. IPSRT focuses on routine and relationships. Family therapy involves loved ones in care. 3. Lifestyle. Regular sleep and routines. Avoiding alcohol and drugs. Practicing mindfulness. Building a support system. Treatment is unique to each person. It takes trial, adjustment, and patience. Let's talk about stigma, the quiet shame that shadows so many people with bipolar disorder. Common myth: people with bipolar are unstable. They're just moody. They're exaggerating. These cause deep harm. Many hide their diagnosis from employers or loved ones. Media portrayals often reinforce stereotypes. There's also internalized stigma. It leads to shame, low self-worth, and isolation. We can fight stigma with education, stories, and empathy. That's why this podcast exists. Recovery isn't about being cured. It means learning to manage symptoms and lead a meaningful life. Jason, bipolar I after a manic episode and hospitalization. Jason now works as a peer support counselor. I've made peace with my mind. Elena, bipolar II, her diagnosis came after years of confusing highs and lows. Now she advocates and writes, "The diagnosis didn't define me. It explained me." The path looks different for everyone, but it is possible. 1. Crisis plan. List early warning signs. Emergency contacts. Medication and hospital info. 2. Daily routine. Regular sleep and meals. Avoid overstimulation. 3. Mood tracking. Apps or journals. 4. Community. Support groups, peer mentors. 5. Self-compassion. Treat yourself with kindness. If you're living with bipolar disorder or love someone who is, know this: you are not alone. Your experience is valid. You are not broken, and there is hope. Thank you for being here. If this episode resonated with you, please like, comment, subscribe, and share. This YouTube video is intended for informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a qualified mental health expert or doctor for personal guidance. Stay safe, stay mindful, stay connected. See you next time on Bipolar Talks.